there, curious minds. Ever stop to think about how the questions on, say, a survey or a medical form are actually designed? You read them, you answer, maybe tick a box, but there's this whole fascinating hidden journey behind making those questions truly effective. Today, we're taking a deep dive into just that, a really powerful technique called cognitive interviewing. Our mission, to unpack how this specialized methodology was used to develop a crucial healthcare tool, ensuring questions are clear, relevant, and capture even the most sensitive patient needs, ultimately improving patient care.
It's definitely an often overlooked step, but, well, it's vital in research. We're drawing our insights today from a detailed study published back in Support Care Cancer in 2009. It's by Nisar Ahmed and colleagues, and the title is The Use of Cognitive Interviewing Methodology in the Design and Testing of a Screening Tool for Supportive and Palliative Care Needs. This research, it really lays bare the challenges, but also the triumphs of crafting a tool for a very vulnerable population.
Okay, so let's unpack this term then. Cognitive interviewing. It sounds a bit like mind reading, doesn't it?
Not quite mind reading, but close. It's a verbal technique. It's designed specifically to help researchers understand how participants interpret and respond to questions. The real aim is to identify confusing questions, or maybe those likely to get an inaccurate response. It's about getting inside a person's head, as they process information from a questionnaire.
Okay, and here's where it gets really interesting, I think. You might assume it's like a new thing specifically for healthcare surveys, right? But this technique actually has a pretty surprising origin story. It was first developed way back in 1984 by psychologists Ed Geiselman and Ron Fisher. And get this, not for surveys, but for improving witness interviews conducted by the police.
That's right. From its roots in forensic psychology, cognitive interviewing has, well, it's become a standard part of developing validated and reliable measures across so many areas of healthcare research now. It assesses a participant's comprehension, their ability to retrieve information, process it, and then how they interpret an answer. It's particularly useful when questions are sensitive or intrusive, or maybe when the target group might find completing the measure problematic for whatever reason.
And what seems key, as the study notes, is that it requires very limited input from the interviewer themselves, which really helps reduce that interviewer-imposed bias.
Exactly. Minimizing bias is crucial for validity.
Okay, now let's zoom in on the specific problem this deep dive addresses: supportive and palliative care.
Before we go further, could you quickly define those terms for us, just to make sure we're all on the same page? Certainly. So supportive care basically helps patients and their families cope with cancer and its treatment. That's from pre-diagnosis right through to bereavement. The focus is really on maximizing treatment benefits and helping people live as well as possible. Palliative care, on the other hand, is the active holistic care for patients with advanced progressive illness. Here, the priority is managing pain and other symptoms and providing psychological, social, and spiritual support. The goal for both is the best possible quality of life for patients and their families. And importantly, both types of care are often provided by family and carers too, not just professionals.
Right, and what's fascinating here is, well, the study highlights that at the time it was conducted, there was no standardized checklist or assessment to prompt a referral to specialist supportive and palliative care.
Exactly.
So referrals often just depended on the individual health professional's knowledge and, I guess, what resources were available locally.
Precisely. And this meant that some patients either didn't get a referral at all, or they were referred much too late in their illness trajectory. The researchers saw this critical need to develop a measure that was both brief, because let's face it, patients with advanced illness have limited capacity for really lengthy forms, and comprehensive enough to cover all those important domains: physical, psychological, financial, social, spiritual needs.
Yeah.
All of it.
And this is where the Sheffield Profile for Assessment and Referral to Care, or SPARC, comes into the picture. It's designed as a multidimensional screening questionnaire, right, to identify patients who could benefit from extra supportive or palliative care, no matter their specific diagnosis.
That's the goal, yes. A tool to bridge that gap.
So how did they actually build SPARC from the ground up? The research team started, as you mentioned, with a systematic literature review.
Very thorough.
Conducted interviews with health and social care professionals, and even spoke directly with patients who had advanced illness. And all that work led to an initial draft, I think you said, with 65 questions, covering areas like communication, symptoms, emotional stuff, spiritual concerns, family support. A wide net.
A very wide net, initially, which then raises that important question. How do you take those 65 potential items and turn them into truly effective questions that actually resonate with the target population? This is exactly where cognitive interviewing became indispensable.
Right.
They used the thinking aloud technique with 7 participants, 6 health and social care professionals, and 1 consumer, a former cancer patient.
Thinking aloud. So literally asking people to say what's going through their head.
Pretty much, yeah. They used 2 main approaches during these interviews. First, the concurrent approach. This involved asking participants to vocalize what they were thinking while they were answering each question, or maybe just shortly after.
Okay, like a running commentary.
Exactly. And then there was the retrospective or debriefing approach. This was more of a discussion immediately after the whole interview was done to get feedback on the overall experience of completing the measure.
And the focus was incredibly specific, wasn't it? Identifying unclear words or phrases, exploring how questions actually worked in getting responses, and assessing how people perceived each item, its usefulness, how they interpreted it.
Yes, it was a very structured approach. They systematically investigated interpretation, suitability for the respondent, their ability to retrieve answers from memory, how they made judgments about those answers, and even their tendency or willingness to disclose certain information.
So the million-dollar question, what did they actually discover when these participants thought aloud? What came out of that initial feedback?
Well, the feedback on that first 65-item version was pretty clear, and maybe not surprising. It was found to be too long, somewhat confusing, often repetitive, and in many places too formal. A lot of the questions just weren't rooted in a way people normally speak.
That formality seems like a real killer in healthcare settings.
Yeah.
People need clarity, not jargon.
Absolutely. Jargon and medical terms were identified as a significant barrier. For instance, there was an original question, do you feel fatigue tired?
Okay.
That got changed to the simpler, much more accessible, do you feel tired? Just removing the jargon.
Makes sense.
Similarly, do you have nausea? Became, do you feel sick? Much more common language. And have you been vomiting? Was rephrased to, have you been sick? Vomiting. Adding the clarification, but starting with a simpler term.
Small changes, but they sound like they'd make a huge difference in just understanding what's being asked, especially if you're feeling ill or overwhelmed.
Precisely. And they also refined broader questions that were maybe a bit too vague. For example, have you been able to speak to someone about your illness? Well, who is someone?
Right.
So that was changed to specify either professional or your family and friends. Much clearer.
Yeah, that helps narrow it down.
And another one. Have you been provided with sufficient information? Sufficient information about what? That was clarified to information about your illness, care, or treatment. Again, adding that necessary context.
These examples really highlight how cognitive interviewing gets into the nitty-gritty of comprehension. It's not just about if they answer, but if they understand what they're answering.
Exactly. And another key finding related to the response format itself. Many participants, perhaps understandably, said they preferred a simple yes-no answer format. Easier, quicker.
I can see the appeal, but
But the researchers realized this could lead to a huge loss of valuable information. You lose all the nuance. Is it a yes slightly or a yes severely?
right, the severity.
The cognitive interviews help them understand this limitation and actually rule out that simple yes-no format. It pushed them towards developing more nuanced severity categories, which give a much richer, more clinically useful picture of the patient's needs. They even identified questions that were completely missing. Things like loss of appetite and weight changes, which are really common and important in advanced illness. Those were subsequently added to ensure the tool was comprehensive.
Wow. So it wasn't just about refining existing questions, but also finding the gaps.
Absolutely. It's a really holistic check on the content and the structure.
Okay. Here's where it gets, I think, really challenging and interesting. The cognitive interviews also highlighted the most sensitive questions. What were those?
Yes, this was a critical finding. The participants, both the professionals who would be asking the questions and the consumer, the former patient, who represented those answering them, they identified questions focusing on finances, sexual intimacy, death and dying, and even religious or spiritual issues as being particularly upsetting or, difficult to talk about. Questions about the illness progressing and general emotional and psychological issues were also flagged as highly sensitive.
That presents a real dilemma, doesn't it? A kind of ethical tightrope for the researchers. How do you balance that absolute need to capture holistic patient needs, because all those things are vital to quality of life and proper care, with the very real potential for causing distress or discomfort when you ask about them.
It's a huge challenge. And what's fascinating here is how the research team handled it. They actually made a difficult judgment call. They decided to keep these sensitive questions in the measure, despite some participants feeling uncomfortable asking or answering them.
Really? Why?
Their reasoning was basically the fundamental requirement to capture those holistic needs if the tool was going to be truly useful for assessing patients comprehensively,
Mm.
especially across large populations. They argued you just can't ignore these areas if you want a full picture.
Okay, but they didn't just leave it there, right?
No, absolutely not. And this is where the cognitive interviewing process proved invaluable beyond just wording. It allowed them to have crucial, proactive discussions about the practicalities of actually using these questions. They talked about how best to introduce these sensitive topics, how to handle situations where a patient might become distressed, what support mechanisms needed to be in place, and reinforcing the absolute importance of confidentiality.
So it wasn't just refining the tool, but also thinking ahead about its use in the real world, ethically and practically.
Exactly. That early exploration and planning, prompted by the cognitive interview feedback, was vital preparation.
It really underscores that developing a tool like this is more than just writing questions. Okay, so we've heard about the benefits, but were there any limitations acknowledged with using cognitive interviewing in this process? No method is perfect, right?
Right. The study is quite upfront about the limitations. The technique is often considered subjective, relying on individual interpretations, and it can feel a bit artificial. Interviewing someone in a controlled setting isn't quite the same as them filling out a form alone. It's also very time-consuming. It generates a huge amount of qualitative data to analyze. Those interviews, as mentioned, could last over an hour for the initial 65 questions.
An hour is a long time for someone unwell.
Definitely. And then there's the analysis time. Plus, there's the argument that a small number of interviews, they only use 7 people here, might not identify all the potential problems.
Hmm.
And you could argue it might be biased against participants who are less articulate because it relies so heavily on them verbalizing their thoughts.
And the sample itself, self-selected.
Yes, the self-selected sample might not be perfectly representative of the entire target population in terms of, say, education level or age range. These are all valid points to consider.
So, quite a few potential drawbacks. But despite those reservations, how did the researchers ultimately view its contribution?
Despite those reservations, the study strongly argues for its usefulness. They position it as a critical first step in the measure development process, especially effective when you follow it up with later, larger-scale field testing. Interestingly, they found that the same themes and comments tended to crop up repeatedly across the different interviews.
Ah, saturation point almost.
Kind of, yeah. It indicated that even this small, purposefully chosen group was revealing significant, recurring issues with the draft questionnaire. The depth of understanding they gained the why behind the problems was something they felt couldn't be achieved easily otherwise. And ultimately, it led directly to a significantly refined measure. They cut it down from 65 questions to a much tighter 45 questions, SPARC 45. And this version was demonstrably clearer, more patient-centered, and ready for that next stage of validation. So indispensable in the end.
That refinement process is just fascinating. So, reflecting on this whole deep dive, what does this all mean for you listening right now? How does understanding this meticulous, behind-the-scenes development process for a tool like SPARC maybe change how you view those questionnaires or medical assessments you encounter in your own life? Maybe next time you see one, you'll have a bit more appreciation for the thought that goes into making a question clear, relevant, and sensitive.
I think this deep dive really illustrates just the sheer power of simply asking people what they're thinking. It sounds so basic, doesn't it? But cognitive interviewing ensures that the tools we use in healthcare, like SPARC, aren't just scientifically sound on paper, but they're also deeply human. They're understandable, and they're sensitive to the actual experiences of the people they're designed to help. It's really about designing with empathy embedded right into the questions.
Exactly. That meticulous, often invisible, behind-the-scenes work of cognitive interviewing transforms complex research goals into usable, empathetic tools. It ensures that the questions we ask truly reflect the experiences we're trying to understand instead of, imposing academic language or assumptions that just don't connect. So next time you find yourself filling out a questionnaire, maybe take a second. Think about the invisible journey those questions might have taken to land on your page. Think about the crucial insights they might have gained from someone somewhere, simply thinking aloud. And it makes you wonder, doesn't it? What other areas of our lives beyond healthcare could seriously benefit from this kind of deep dive into how we truly understand and respond to information? something to ponder until our next deep dive.